And when it is happening suddenly, we'll call it acute renal failure. Or if it occurs because of secondary illness of the kidney and it takes time and it is slowly progressing towards a renal failure, then we call it chronic renal failure. So acute kidney injury is a new terminology, and it is an interusable terminology. Sometimes we call it, nowadays we call it acute kidney injury, but formerly it was used to call as acute renal failure. The clinical syndrome which we are going to get in this kind of case, that there will be sudden deterioration in renal functions, and we know that we want to look at the urea and creatinine of the kidney. These are the two byproducts of the metabolism within the body which are supposed to be excreted out of the kidney. So when the urea and creatinine is not going to be excreted by the kidney because of the decreased renal functions, there will be sudden increase in renal functions, and which would be predicted by urea and creatinine. We know that kidney is doing the other thing, which is to balance the fluid level within the body, and electrolyte homeostasis, like potassium has to be within a normal range, which is around 3.5 to 5. Similarly, sodium, similarly, potassium is the main electrolyte. We all know that hypovolemia or hyperkalemia is something which can affect the body in a major way. So usually it occurs in 2 to 3% of children admitted in pediatric tertiary care centers. We're talking about acute kidney injury, means something which is happening because of some acute illness and causing some acute deterioration in renal functions. So it has been seen multiple times that it is 2 to 3% of the children who are admitted in pediatric tertiary care centers are the ones who do develop acute renal injury. 8% of the infants in neonatal intensive care units do develop acute kidney injury. So by the numbers, by the percentage, you can see children are the ones who are more than 1 month of the age and less than 13 years in Pakistan setup, but all over the world, sometimes they do take it below 16 years or 18 years in the pediatric age group. So children who are more than 1 month of age, they do develop 2 to 3% of the acute kidney injury, while neonates who are less than 28 days of life, they are more fragile. When they do get admitted in intensive care units, there's a chance of 80%. The incidences means this is already happening. So if you see, this is more than double that in neonates, they can get acute kidney injury. Our classification system has been proposed in acute kidney injury. This classification is based on the risk factors, basically. You can say, okay, when you look at the kidney functions and you look at the urinary output, you categorize them into 5 categories, which is if you use a mnemonic or acronym, we call it RIFFLE. You can see that R stands for the risk, I stands for the injury, F stands for the failure, L stands for the loss of the kidney, and E stands for the end-stage renal disease. So this acronym can be used when you try to categorize the acute kidney injury in adults. But if you modify this RIFFLE acronym for the renal failure, we can modify it. This was modified with P-RIFFLE, which is pediatric RIFFLE, and actually the RIFFLE is same for the pediatric age group as well, which is R stands for the risk for the kidney injury, I is the injury which has already happened, failure means kidney failure has happened, loss means loss of the kidney has already happened, and E is the end stage renal disease, which is the loss can till the failure, you can say these are the reversible conditions, but loss of the kidney and end stage renal diseases are the conditions which are not reversible. So when we talk about the RIFFLE or pediatric modified RIFFLE criteria, you look at the right side which says, wait, sorry. I'm trying to, okay, I was trying to use the arrow, but I cannot somehow. I think it's the full screen for that reason. So if you look at the leftmost, the heading of criteria, you can see this is the RIFFLE, that risk, injury, failure, loss, and end stage. If you talk about the estimated CCL, CCL is creatinine clearance. C is creatinine, CL is clearance. So small e is basically telling you estimated. So estimated creatinine clearance, which occurs through the kidneys when it decreases by 25%, it means that the kidney is at risk of injury, right? And if you just look at the urinary output, so means if a child comes to you and wait, sorry. Okay, so if you look at the urine output and if you see a child is admitted in a pediatric intensive care unit and you see that the urinary output of that child is less than 0.5 ml per kg per hour for 8 hours, you would say this child's kidney is at risk of acute kidney injury, right? So, you know that normal urinary output in a pediatric age group is between 2 to 4 ml per kg per hour. If assume if a child is of 10 kgs and you assume that the normal urinary output is 2 ml per kg per hour, so you would say that that child would be passing 2 ml per kg means 20 ml per hour, okay? And if you see that child of 10 kgs and in last 8 hours you see that the child has just passed 5 ml means if it is 10 kgs, so it means 0.5 ml per kg. A 10 kg child would be passing only 5 ml urine in 8 hours. So it means if you see a child who is 10 kgs, for example, I'm just giving you an example so that you can very easily understand, is passing less than 0.5 ml per kg per hour for 8 hours, it is an alarm to look at the child in a very detailed way, what's going on, what are the risk factors, we are going to discuss later. So that child is at the risk of kidney injury. But injury would be occurring if the same urinary output, which is less than 0.5 ml per kg per hour for 16 hours. If you would pick it at 8 hours, it means, or within 8 hours, it means this child has, wait, let me check. Achha, okay. So somebody raised the hand. I think I'm going to answer later. Somebody raised the hand. After the finishing my presentation, I would answer you, whoever has raised the hand. So, okay. So, if you look at this, so 0.5 ml per kg per hour for 16 hours means double to the hours of risk. It means a kidney injury has occurred. But luckily, this kidney injury is still this stage where we can reverse the condition. If failure is happening, means that the amount is going to be decreased by less than 0.3 ml per kg per hour for 24 hours. यानी एक बच्चा है जो 10 किलो का है, उसका यूरिनरी आउटपुट 24 घंटों में सिर्फ और सिर्फ 3 ml है, तो you will call it that this child is having failure of kidney. And similarly, if the child is anuric for 12 hours, means he is not passing a single ml of urine for 12 hours, you say this child has developed failure of the kidney. But when this condition, which occurred in failure, and it has been happening for the last 4 weeks, then you would say this child has lost the kidney. And the same condition persists for more than 3 months, you will call it end-stage renal disease. So this is something which is a bit tricky, but I would suggest you can just focus on the urinary output if it is less than 0.5 ml, the number per kg per hour and hours. So less than 0.5 ml per kg per hour for 8 hours, same amount for 16 hours, and almost same but 0.3 ml per kg per hour for 24 hours, or anuric for 12 hours. You will say that this child is having failure. And if this condition would persist for more than 4 weeks, you would say that there is loss of kidney. And if it persists for more than 3 months, it means it is end-stage renal disease. And after that, you need to put the child on dialysis. It could be peritoneal dialysis, it could be hemodialysis, and that's a bridge actually, because the appropriate or the ultimate treatment for the end-stage renal disease is renal transplant. So, oh God. Okay, so wait. So what is the pathogenesis? We said there is acute kidney injury. I told you the criteria of referral in which we are going to classify either this is risk, either this is injury, either this is failure, or this is loss, or end-stage renal disease. Now we would like to look into the three categories of acute kidney injury. So there are three basic types. We know we're talking about the kidney. So a failure which is happening, or a kidney injury which is happening before the kidney issues, it will be called as pre-renal. If something is happening within the kidney, it will call it intrinsic renal failure. And if it is happening because of something which is happening after the kidney level, it will be called as post-renal. The pre-renal, intrinsic, and post-renal are the main classifications of acute kidney injury. So, common causes of acute kidney injury, if we talk about the pre-renal acute kidney injury or pre-renal azotemia, we would categorize it by three ways. Either diminished effective circulating arterial blood. We know before kidney we can talk about the blood flow. Lead, which is like if there would be less blood flow to the kidney or the arterial volume to the kidney, it would lead to decreased renal perfusion. When there will be decreased renal perfusion, there will be decreased glomerular filtration rate, which is being happening through the glomerulus, and evidence of kidney damage is absent. Means kidney damage evidence means something within the kidney is not happening, which is wrong, but it is something which is before the kidney. So the major causes of pre-renal injury is dehydration. We know if a child comes to you with diarrhea, vomiting, not taking sufficient amount of water and losing a lot of water in the form of diarrhea or vomiting, then there would be dehydration. And when there will be dehydration, there will be hypovolemia. If there will be hypovolemia, there will be hyperperfusion of the kidney. And when there will be hyperperfusion of the kidney would not be able to excrete the end products of the metabolism of the body, right? Hemorrhage. Dehydration is something in which plasma is going to be down because of the water deficiency or dehydration. In hemorrhage, there would be loss of blood. There will be loss of blood. For that reason, the blood volume would be low because of the hemorrhage, and for that would cause hyperperfusion of the kidney. Sepsis is the condition in which there is most of the time there is hypotension because of the septicemia or sepsis. The hypotension means blood pressures would be that low, although the volume of blood would not be low in the form of plasma or the RBCs or the other components of the blood, but heart would not be able to pump the fluid in a proper form, so that there would be hypotension, and that can be because of the disseminated DIC, which can cause hypotension. Similarly, hypovolemia. We know we talked about the albumin in nephrotic syndrome. Whenever there will be hypoalbuminemia, there will be less osmotic pressure within the blood vessel, and it will cause extravasation of the fluid. The plasma or the water content of the blood would go out of the blood vessels. So ultimately, within the blood vessels, there will be less blood pressure, and for that reason, it will cause hypertension. Similarly, cardiac failure. In cardiac failure, heart is the main pumping station. If the main pumping station would not be working properly, it would not be having sufficient amount of pressure to produce, to throw the blood far away organs. So kidney lies far away from the heart. So if there will be cardiac failure, there will be less ejection fraction, and that less ejection fraction is going to cause compromised kidney perfusion. So if the underlying cause of hyperperfusion is reversed promptly, renal failure returns to normal. So we're talking about pre-renal failure. We know if there's dehydration, we are going to give the fluids. We know if there's hemorrhage, lots of blood has lost, we can give blood, or we can give plasma expenders. If our child is having sepsis, in that case, we can give inotropic drugs, which can increase the blood pressure. And similarly, in the cardiac failure, we will give inotropic medicines, which are going to increase the cardiac pumping. And in hypoalbuminemia, if you will give albumin, we are going to increase the osmotic pressure within the blood vessels, and ultimately the plasma would stay within the vessels, so it would cause proper perfusion of the kidney. So these the pre-renal conditions are basically the reversible conditions in which we can work appropriately according to the cause, and we can treat the pre-renal failures, right? In intrinsic renal kidney injury, it can be because of the glomerulonephritis. We talked about in previous lecture, we talked about the previous lecture, post-infectious glomerulonephritis. It could be lupus erythematosus, in which there can be nephritis. In inox-Schönlein purpura, there can be nephritis, membranoproliferative condition, anti-glomerular basement, and these are the conditions in which there will be glomerulonephritis, and it is the problem in which there would be intrinsic renal problem, means kidney glomeruli and the tubules would be so much affected that it is not going to function properly. Similarly, HUS, acute tubular necrosis, cortical necrosis, renal vein thrombosis, acute interstitial nephritis, tumor infiltration, tumor lysis syndrome. These are the conditions in which there is nothing related to the pre-renal failure or post-renal failure. It is because of the renal failure which is happening within the kidney. So, in post-renal, if we talk about in intrinsic, there will be problem within the kidney. But in post-renal, there will be problem outside the kidney. So outside means after the kidney, pre, before the kidney, post, after the kidney, and renal within the kidney. So in post-renal, there can be posterior urethral valve, which usually occur in the male infants, uretero-pelvic junction obstruction, which can be due to a web, which could be congenitally present. It could be because of the stone impaction. Uretrovesical junction obstruction, again, it can be because of some congenital problem, or it could be because of, stone. Uretroceles, this is abnormal structure of the ureters, which can cause obstruction. Tumor of the urinary tract. Urolithiasis, I told, it can impact at uretropelvic junction or uretrovesicular junction, or even at the urethral region. Urolithiasis can affect the outflow of the urine. Hemorrhagic cystitis. In hemorrhagic cystitis, there's a lot of blood, so it clots a lot. So ultimately, it clogs the urethra, and ultimately it causes the obstruction of the urinary outflow, and it causes post-renal failure. And neurogenic bladder. Neurogenic bladder is the bladder in which the walls are so dilated that it doesn't contract properly. So urine stays within the bladder even after passing the urine. So that increased amount of urine in the bladder can cause backflow into the kidney, and that backflow, all these obstructions can cause the backflow of the urine within the kidney, that causes the hydronephrosis, and ultimately hydronephrosis can lead to the renal damage. So post-renal actually ultimately is going to cause renal failure because of the intrinsic issues. So when we talk about the clinical manifestations, we need to look at the clinical, we need to take a proper detailed history, because history is going to tell us either this seems like a pre-renal or post-renal or renal issue. If we talk about pre-renal, we would be asking about either child was having diarrhea or any infection, or was there any hemorrhage. So these are the conditions that are going to give us the clue. The history points are going to give us the clue of pre-renal. But when we talk about renal issues, we know nephritic conditions are mainly the problems which can cause intrinsic renal failure. And in that, you can have a history of hematuria, you can have a history of, previously something going on for months or years. And if you talk about the posterior post-renal obstruction, in that there's a chance that child was able to pass urine initially. Now he has started passing painful, there is painful micturition, or he is passing less amount of urine. So these can give us the clue of what's going on actually with the kidney, whether it's pre-renal, renal, or post-renal. The physical examination must be thorough with careful attention. So any diagnosis cannot be completed if you would not take a proper history, or you would not do the proper physical examination. Like we talk about the post-renal failure, we said they can be tumors. So in that case, if you would do the examination, in tumors can be palpated in kidney region or even in the bladder region. So examination is very important. So what lab findings you would like to go for? You would like to go for to look for anemia. For that, you would do CBC. You would like to look for leukopenia and thrombocytopenia. These first three is going to okay. Wait. It's not coming. Okay, so first three is anemia, leukopenia, and thrombocytopenia. These three we can look by doing CBC, in which you can see low TLC count, low hemoglobin counts, or low platelet counts. Hyponatremia, that can be because of dilutional in the form of, then there will be cardiac failure, and then when when the kidney is not able to pass urine, there will be a lot of water within the body, so it would cause hyponatremia. Metabolic acidosis, we know kidneys are supposed to excrete hydrogen ions, so metabolic acidosis can occur in ABGs, so you would like to go for the ABGs. Okay, sorry, just wait a minute. Just wait a minute. Okay, so elevated concentration, we talked in the initial slide that increased urea and creatinine is going to tell us that kidney is not functioning normally, because when kidney functions normally, urea would be in normal range, creatinine would be in normal range as per the age and the gender. There can be high uric acid levels when there is some tumor lysis syndrome. The potassium and phosphate levels can be diminished when the renal functions are diminished. Potassium would be high and phosphate levels would be high when the renal is not functioning properly, because kidney function is supposed to be to excrete excessive potassium and excessive phosphates. Hypocalcemia, which could be because of hyperphosphatemia. Whenever there will be high levels of phosphate within the body, it is going to chelate the calcium. So ultimately, it's going to decrease the calcium levels in the blood. And C3 levels may be helping to look into the intrinsic renal failures, like in nephritic conditions, C3 levels would be depressed, which we talk about in acute post-streptococcal glomerulonephritis. We can see it in low C3 levels. In SLE, we can see C3 levels would be low in case of any immune-related nephritis. So we'll go for the chest radiograph because we want to look at volume overload. And in case of volume overload, the chest X-ray would be showing pulmonary edema, right? Renal ultrasound to look at any renal pathology in the sense of structure. It could be hypernephrosis, could be tumor, it could be urolithiasis. Renal ultrasound is going to help us. So we'll go for CBC, we'll go for serum electrolytes. Metabolic acidosis can be seen by the help of serum electrolytes, because in that bicarb would be low. In case of metabolic acidosis, you will look for urea creatinine, you will look for uric acid, potassium and phosphate. You can need to order phosphate, alloxate and calcium and C3 levels, and ultrasound and chest X-ray. So treatment basically depends upon what is the reason of renal failure. If it is pre-renal failure and it is because of hypoperfusion or dehydration, in case of urinary tract obstruction, you are going to urinary tract obstruction would be occurring in post-renal failure. So post-renal acute kidney injury, in that you are going to catheterize immediately, so that you would avoid the backflow of the urine. So catheterization is going to help to help in the ease of outflow of the urine through the urinary tract. If there is no evidence of volume overload or cardiac failure, IV volume should be expended by IV administration of isotonic saline, which is normal saline, with a dose of 2 ml per kg over 30 minutes. In the absence of blood loss or hyperproteinemia, colloid containing solutions are not required. So if you see there is no blood loss or if there is no hyperproteinemia, you don't need to give colloid containing solutions. You can just give normal saline to expend the plasma. After volume resuscitation, hypovolemic patients generally void urine within 2 hours. If he is hypovolemic because of low plasma within the body because of dehydration, if you will resuscitate them with fluid resuscitation, volume resuscitation means when you are going to give the fluid, normally they pass urine within 2 hours. Failure to do suggests intrinsic or post-renal failure. If you are resuscitating a person with volume, with fluid, and he's not passing urine, then there's a chance that within the kidneys there's a problem, so it's not able to excrete urine, or there could be post-renal. Other medications we talked about.
Yeah.
Hello, who is this talking in between? I'm sorry. Please mute your mic. Other medications could be norepinephrine or dopamine infusion. These two medications are basically the inotropic medications. This norepinephrine and dopamine infusions are the ones which is going to increase the contractility of the heart. So in case of cardiac failure, secondary to septicemia, this norepinephrine and dopamine infusion is going to help. Similarly, diuretic treatment only after correcting the hypotension. If you feel as a person is not having sufficient amount of volume of blood and is hypotensive, in that case, you would not give diuretic, because otherwise you are going to make him more compromised phase, and that person may go into more hypotension and hypovolemia. So, indication for the dialysis, we talked about that there would be oliguria, there would be hyperuremia, there would be increased creatinine levels, there would be metabolic acidosis. In that case, the dialysis is something which is an ultimate treatment for AKI if it is not being treated with the fluid or with the medication. So whenever there is anuria or oliguria, I mean a patient, anuria means not passing urine for more than 12 hours, or oliguria when the urinary output is less than 1 ml per kg per hour. I'm talking about the children. You're not going to take this for adults. So oliguria, when there will be less urine, less than 1 ml per kg per hour, you are going to see for 12 hours or 8 hours. So volume overload with evidence of hypertension. When you see that person is not passing urine completely, or there is very less quantity, which is less than 1 ml per kg per hour, it means there's a chance of volume overload. Means the body is containing more amount of water within the body. You would look for the blood pressures. If there is hypertension, this is a sign towards volume overload, that body is having a lot of water in it. And or pulmonary edema. We said we would look for the extra chest, and extra chest is the one which is going to tell us about the pulmonary edema. And you on X-ray you can see bad wing appearance. I'm sorry I didn't share the the X-ray. I would try to, when I'll put this when this I'll upload this lecture, I would try to put an X-ray in it as well, so you can look into the what kind of chest X-ray would be there with pulmonary edema. They can be persistent hyperkalemia. You know, when potassium levels should not be more than 5.5 in adults, but in neonates it can be afforded by 6.5. But whenever the potassium levels are higher than normal as per age, you would say the kidney is not functioning properly. You would go for dialysis. So dialysis is what? Dialysis is basically an artificial kidney, man-made kidney, which is going to work for the person. So severe metabolic acidosis, unresponsive to medical management, means you have given the fluids, you have given the bicarb. Despite that, metabolic acidosis is not being corrected. You would go for dialysis. Blood urea nitrogen is more than 100 to 150, and you know that whenever there will be high urea levels, there will be a lot of, like, there will be a patient may go into coma, he can get disoriented, he can get pericarditis. For that reason, you need to get the levels down by doing dialysis. Calcium phosphate imbalance with hypocalcemic tetany. Whenever there will be high phosphate and low calcium levels, there would be tetany, there will be abnormal contraction of the muscles. In that case, you need to give calcium. If calcium treatment is not working, then you need to go for dialysis. So prognosis, the mortality rate in children with AKI is variable and depends entirely on the nature of the underlying disease. If it is a pre-renal failure, you may be able to correct it, but if it is intrinsic, then probably it has got bad prognosis. But if it is post-renal, again, if you catheterize the patient and you go for surgical corrections, chances are that the prognosis would be good. For example, post-infectious glomerulonephritis has a very low mortality rate. You know, this condition is not the lethal one, so in that case, hardly less than 1% children do get, have bad prognosis, or the mortality rate is less than 1%. While AKI related to